All right, we're going to talk about care in normal pregnancy now. The initial prenatal visit ideally is preconception. We at least would like to get them in the first trimester because later prenatal care is associated with increased risk. I want you to consider some of the barriers that patients may face in getting to prenatal care in that first trimester or getting to prenatal care consistently. There are things like lack of knowledge and personal mental health considerations, but also there are logistical challenges like not being able to get off work, not being able to find a provider that takes their pay source, not being able to get transportation consistently. So those are all things that may affect patients being able to get adequate prenatal care. Standard care is a visit every 4 weeks until 28 weeks, and then every 2 weeks until 36 weeks, and then weekly after that until delivery. Some testing that's done in early pregnancy, that patient is going to have a type an RH, a CBC, a UA, and that may actually be repeated at each visit or at most visits. Urine HCG or serum HCG to establish, yes, we have a positive pregnancy test. Hepatitis B serology, syphilis testing, either RPR or VDRL, because both of those conditions can affect the fetus. And then based on risk factors, they may get a drug screen, they may have HIV testing for chlamydia and gonorrhea, they may get a pap smear, or they may have a TB test. There is a test done around 15 to 22 weeks, and it's changed over the years. It started with just an AFP, alpha fetoprotein. Then they added something and they added something else. It was the triple screen, then the quad screen. Now I think there's 5. It's a penta. And it includes nuchal translucency screening as well. What you need to understand about that is it is a screening test only. It can identify, hey, this may potentially have some issues. A couple of things it can trigger further investigation for are Down syndrome and neural tube defects. You need to know that it's not diagnostic. This is a maternal blood test, and it shows markers that may indicate those issues. And so if anything pings on this test, the patient does not need to be told, oh, your baby may have or probably has Down syndrome. They need to be told, we need to do further testing because this test indicates there's a possibility, but it is not diagnostic. Because a lot of parents have been told, oh, we think your baby, or what they hear is we think your baby has a neural tube defect, and then they find out later it's not the case. And that's really a terrifying few days or weeks. So we've got to be really careful how we present those results. Glucose tolerance test is done at 24 to 28 weeks to identify gestational diabetes. A pelvic ultrasound might be done in the first trimester for gestational age and the second trimester for growth and development. Amniocentesis may be done in the first trimester to screen for genetic and chromosomal abnormalities. In later pregnancy, a CBC is repeated, usually around 28-30 weeks, because at 28 weeks, there's an increase in blood volume, which causes dilutional anemia. So a lot of patients become anemic around this point. A CBC is done again, usually near term, to determine how well that patient can oxygenate the placenta and how well can they withstand blood loss in labor. Because if they go into labor very anemic and then they hemorrhage, they have less blood to lose. There's also some normal blood loss in labor, and they may not even be able to withstand that. Pelvic ultrasound is done in later pregnancy to assess growth fluid levels. They can do a test called the Biophysical Profile, BPP, that looks at several measures to get an estimate of placental adequacy. If there's a suspected injury to the placenta, like maybe they're in a car accident and steering wheel hits the abdomen, something like that, they can do what they call a KB stain, Kleinhauer-Beck, I think. And it looks for fetal hemoglobin in the maternal blood. So it would indicate a possible placental injury. If they're suspected to be in preterm labor, they can do a vaginal swab for fetal fibronectin. The presence of fetal fibronectin indicates delivery is a possibility. The absence of fetal fibronectin indicates that delivery is unlikely within the next 2 weeks. So it's a really better negative predictor than positive. They also do some tests of fetal well-being during the last part of pregnancy. They want to see just how the fetus is doing. One of the things we want to do is ask the pregnant person to pay attention to fetal movement beginning around 28 weeks. If they notice a reduction in fetal movement or that fetal movement has stopped, they need to call the provider immediately. A reduction in fetal movement is associated with intrauterine growth restriction and with intrauterine fetal demise. They should report if there are fewer than 10 movements in 3 hours, if the movements are slowing down overall, or it takes longer and longer to get to 10, or if they have no movement. We can also use a fetal monitor to do some fetal testing. The fetus can be monitored by ultrasound, fetoscope, or continuous electronic fetal monitor, and contractions can be monitored by either palpation or a continuous electronic fetal monitor. The electronic monitor shows 2 continuous graphs, and I'm going to show you an image of that now. Okay, the upper graph is fetal heart rate, and the lower graph is contractions. When we monitor contractions, we document the frequency, and that's from the beginning of a contraction to the beginning of the next. So we can say that these contractions are about 7 minutes apart. The dark lines are a minute, the light lines in between the dark lines. There's a dark line that's 20 seconds, or a light line that's 20 seconds, and an even lighter one that's 10. So that's how you can tell where we're at. We measure I'm looking at my notes. We measure the duration, which is from beginning to end. So these last 60 to 80 seconds. So we've got 2 contractions, 7 minutes apart, lasting 60 to 80 seconds. And then we palpate them to determine how strong they are. Now, if this patient is in labor and has an internal monitor, we can look at actual strength of contractions, but we can make these hills get higher by tightening that belt or changing the position. We can make them get lower by loosening that belt or changing the position. And so we cannot measure strength with an external monitor. We have to palpate. Okay. This external monitor is actually documenting the contractions because of pressure on a pressure sensitive button. So this is strapped to the abdomen. As the uterus contracts, it puts pressure on the button, and that's what draws the picture. So if you move that button to a different location, different angle, looser, tighter, you can change what this looks like. Okay, so we need to palpate for strength of the contractions and palpate for resting tone, which is to make sure the uterus contracts completely in between. An internal monitor, if it's correctly calibrated, can measure the exact intrauterine pressure at all times. So if this were an internal monitor, this would be 10 millimeters mercury resting tone, and the contractions are at 70 millimeters of mercury. You cannot do internals until that patient they're actually committed to deliver, because the water has to be broken. So let's look at the fetal heart rate piece. We can monitor the fetal heart rate with either a fetoscope or a Doppler, or with an external fetal monitor. With a fetoscope or Doppler, we're doing intermittent monitoring. We want to monitor with contractions, and we can follow ACOG guidelines for that process. With an external fetal monitor, this uses ultrasound to pick up the fetal heart rate. It can pick up maternal heart rate instead of the fetal. So you've got to make sure, how would you make sure that this is the fetal heart rate and not the maternal? I've been involved in a situation where a patient presented a labor and delivery who had the flu. We were monitoring at 120, and they discovered a little while in that was actually the mother's heart rate and not the fetal heart rate. The fetal heart rate was in the 180s because she had fever. Okay, so you assess this by comparing this to the maternal pulse. There are monitors that actually will trace the maternal heart rate along with the fetal so that you can see that there's a difference. Sometimes this ultrasound doesn't pick up clearly in some situations because of either position of the baby, position of the mother, or distance. The baby's moving around a lot. So sometimes you don't get a great tracing. Internal monitor uses an electrode of very fine wires placed just under the surface of the scalp to directly monitor the fetal heart rate. That shouldn't be placed in a non-cephalic presentation. And again, if you're using internals, that patient has to be in labor preparing to deliver because there's the water has to be broken. We're going to look more in depth when we talk about labor into how to read this fetal monitor part or the fetal heart rate part of this. But we've got fetal heart rate here, contractions here. Okay. An NST is when the fetus is monitored continually for movement and heart rate, and contractions are also monitored if they're happening. And that goes on for about 20 minutes. So let's look for a reactive NST. It'll only take me a second to find this. All right, so let's look at this reactive NST. Okay, so to determine this is reactive, the fetal heart rate has to be between 110 and 160. So here's 110, fetal heart rate baseline. Here's 160. So the fetal heart rate baseline needs to be between 110 and 160. They need to have moderate variability. We're going to talk about variability in the next section, but that's talking about how much this heart rate varies from beat to beat. And this has got really good variability. We've got the moderate is between 6 and 25 beats a minute. We're going to exclude these little accels here, these bumps up, and look just here. And there's a variation that's greater than 6 beats per minute, right? We've got from 120 to looks like 140, almost 140 here. So we've got moderate variability. At least 2 accelerations, that's when it goes above the baseline. At least 15 beats per minute, so it goes at least 15 beats up. The baseline is around 130 and it goes up to 160. So yes, it's over 15, and they have to last at least 15 seconds. And these last significantly longer than that. So this is a reactive NST. It indicates that the fetus is actually being perfused well at this point. Okay. A non-reactive NST, and I'm going to take just a second to find one. Okay. A non-reactive NST shows no heart rate acceleration within 40 minutes. So this strip is 1, 2, 3, 4, 5, 6, 7, 8. This strip is 10 minutes. So this by itself cannot be a non-reactive NST, but if it looks like this for 40 minutes, that is non-reactive. We're not getting any accelerations here. And we've got minimal variability. You see how this line varies less than 6 beats per minute? That's minimal variability, no accelerations. This is a non-reactive NST. So an NST helps get an idea of how well the fetus is being perfused. If that NST is non-reactive, they can do a fetal acoustic stimulation test. And I don't know if you've ever seen a fetal acoustic stimulator. Most of them that I've seen are actually shaped like an otoscope handle with that. But when you activate them, they buzz and vibrate very, very loudly. So they're held against the abdomen near the fetal head and activated for 2 to 5 seconds. If the fetal heart rate accelerates in response to that, it's considered a positive response. If the fetal heart rate doesn't change or decelerates in response to that, that means when you startled that fetus, its heart rate dropped instead of going up. That's a negative response. You have to repeat every minute times 3. If it doesn't accelerate, you repeat every minute times 3 before you report a negative response. A biophysical profile ultrasound may be used to evaluate fetal well-being. We mentioned it earlier. It can identify a compromised fetus, but it doesn't guarantee an outcome. And none of these can guarantee an outcome. They can just help you identify, is this fetus in trouble now at this moment? BPP is used primarily in high-risk patients. There's a score out of 10 points. There's 2 points each for fetal heart rate reactivity. So they're using an ultrasound imaging to look at this. So they're looking at fetal heart rate reactivity, fetal body movements, how much is that fetus moving around, fetal muscle tone, do they have good tone, are they flexed or are they kind of floppy, fetal breathing movements. The fetus actually makes breathing movements in and out during pregnancy, and that helps develop the lung tissue to be able to breathe afterward, as well as the muscles to be able to breathe. So if they're not doing that, they may be compromised. And amniotic fluid volume. Amniotic fluid is a strong indicator of placental perfusion, because what amniotic fluid is it's primarily fetal urine. So what does urine output tell us about a patient? It tells us that their kidneys are being perfused. So if urine output drops, their kidneys are getting less urine or getting less perfusion. If our fetal urine output drops, if our amniotic fluid drops, they're not being perfused as well. Normal finding on a BPP is 8 to 10, as long as the amniotic volume is normal. If a score is less than 4, the provider should consider delivering immediately. Equivocal scores, that's 8 without enough fluid, or 4 to 6 if they do have enough fluid, they indicate a need for further testing. Another test that may be done using the fetal monitor is a contraction stress test. It's used to evaluate how adequate the placental and fetal circulation are. They induce uterine contractions with the fetal monitor in place. Contractions actually cause a transient decrease in perfusion, and I'm going to look up one of these really quickly. They actually cause a transient decrease in perfusion. And so we want to look at how the fetus tolerates that. So the first one we're going to look at is a negative contraction stress test, and you want a negative contraction stress test. Okay, this one's weird. You want a negative contraction stress test. That means that the fetus can handle those contractions okay. So negative means that they have accelerations or that they have no later variable decels with contractions. So this patient is having contractions, and if you look at the fetal heart rate, it doesn't drop with those contractions. Okay. Now we're going to look at a positive contraction stress test, and we're going to get more in depth into this fetal monitoring later when we do the labor part. All right, so we've got a positive contraction stress test. Here we have contractions, and with each contraction, you have a little deceleration at the end of the contraction. These are called late decels, and we're going to talk about them more later on. So if they have late decelerations with a contraction, that is not a good sign, but it's called a positive contraction stress test. And they're probably going to go ahead and try to deliver this fetus. Okay, The next section, we're going to talk about complications of pregnancy.